The architecture of medical bias. The medical profession in the United States operates on a foundation of documented inequality that disproportionately endangers the lives of women of color. This is not a series of isolated incidents, but a structural phenomenon known as weathering, where the chronic stress of systemic racism causes premature biological aging and the rapid deterioration of the cardiovascular, metabolic, and immune systems. For women of color, entering a hospital often means entering a war zone of clinical suspicion. Studies published in major medical journals reveal that Black women are significantly more likely to have their pain underestimated or entirely ignored by providers. This stems from a persistent false belief held by a staggering percentage of medical students and residents that Black patients have higher pain thresholds or less sensitive nerve endings, a myth that leads to a 22% lower rate of pain medication administration compared to white patients with identical symptoms. The diagnostic process is further compromised by the invisible patient effect. When women of color present with complex neurological or internal symptoms, their complaints are statistically more likely to be dismissed as psychosomatic or emotional, rather than physical. This bias leads to catastrophic diagnostic delays for life-threatening conditions like cerebral aneurysms, cancers, and toxic drug reactions. Furthermore, the medical record itself is often used as a tool of character assassination. Research into electronic health records shows that doctors are more likely to use stigmatizing language when describing women of color, employing terms like non-compliant, combative, or difficult. These labels create a digital blacklist that follows the patient from office to office, ensuring that every subsequent doctor approaches them with a lens of suspicion rather than care. This systemic failure is most visible in maternal mortality rates, where Black women are 3 times more likely to die from preventable complications than white women, even when controlling for income, education, and insurance status. The profession's history of utilizing women of color for medical experimentation without consent has evolved into a modern culture of medical gaslighting. In this environment, the patient's lived experience is treated as secondary to the doctor's internal biases. When a woman of color advocates for herself, she is often met with the weaponization of her personal history or social standing to invalidate her claims of malpractice. The result is a cycle of institutional betrayal, where the very people sworn to do no harm become the primary agents of a demolition of health and dignity. This data proves that the medical system does not just fail women of color by accident. It is currently structured to overlook them.